Thank you so much for joining us for today's Grand Rounds. My name is Tanya Anand. I'm a clinical assistant professor at the University of Arizona, and we'll be moderating the session for today. The topic for today's discussion is pain control in the traumatically injured and acute care surgical patient, and we have three wonderful speakers here with us today. We have the first speaker is Dr. Saskya Byerly. Dr. Byerly is an associate professor of surgery at UTHSC in Memphis, Tennessee, and is a trauma surgeon and surgical critical care intensivist at Regional One Health. She grew up in Southern California, went to USC for her surgical residency and Ryder Trauma Center for her trauma and critical care fellowship. Then we have Dr. Megan Lundy. Dr. Lundy is a clinical assistant professor of surgery at Thomas Jefferson University Hospital in Philadelphia. She's within the Division of Acute Care Surgery. She did her residency at Wake Forest, followed by an AAST fellowship at the University of Arizona in Tucson. She has specific interests in geriatric trauma, quality improvement, and injury prevention. And then we have Dr. Asanthi Ratnesekera. Dr. Ratnesekera is an assistant professor and the associate trauma medical director at Christiana Care in Newark, Delaware, the only level 1 trauma center for the state, and is also the director of surgical research, overseeing research for the Department of Surgery. She completed her surgical residency at the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine and pursued a surgical critical care fellowship at Virginia Commonwealth University. And her research is focused on traumatic brain injury and preventing venous thromboembolism. So we'll get started here with Dr. Byerly.
See if can remember how to share my screen here. All right. So I think I have the most basic of the topics, thankfully, because the other topics seemed a lot harder. Mine's just on pain control for trauma patients. And I want to thank our director of our acute pain service and regional anesthesia, Dr. Arvind Chandrasekhar, because he provided some of the slides regarding the blocks that we use at Regional One Health. If I can click through. Okay, here we go. I have no disclosures. So this does not really partition the space here, but I was going to talk a little bit about what we did in the ICU with our critically ill patients, sort of the regional pain control options, and we tend to use them both in the ICU, like in the ICU, but also in the step down and on the floor, and then the multimodal options that we try to use in all phases of care whenever we have enteral access, but tends to be predominantly what we use in the floor and step down settings. So our ICU protocol is pretty much comes just from the SCCM 2018 guidelines, which is this clinical practice guideline they had. And two of my partners, Emily Leonard and Dina Filiberto, are really the ones that put together our protocol. And I think kind of the main thoughts from the SCCM recommendations that are reflected within our protocol is just that you want to manage pain or assess pain using validated tools. You want to treat pain with opioids for non-neuropathic pain prior to considering sedatives, and to consider non-opioid analgesia as adjuncts to reduce opioid dosage. So I just wanted to show you some screenshots from our app, which is something I think that's worked really well for us in terms of just disseminating some of our protocols. Before we had the app, we were just kind of using a PDF file that would get updated every 3 years and was available on our intranet, but frequently people didn't really look at it. And then if you wanted to update protocols, a little bit more frequently, you would have had, I guess you could still just load it up to the intranet, but I think with like our trainees and whatnot, this just goes over a lot better. People are used to using apps. Every time you reopen it, it'll just kind of load the latest version of everything, which I think is super helpful. So I'm just kind of showing you when you open the app. I was going to show you a screenshot from my actual phone, but then I didn't want you to see all my other apps. So I just showed you, I'm just showing you within the app. So it's kind of like divided into different sections. So for this, you would go to the surgical critical care section. And then you'd go to pain, agitation, delirium, PAD guidelines. And then you can't really read this super well, but if you were to blow it up a little bit, it looks like this. And you can just kind of see we use CPOT as our validated score. And then we also have RAS in here for the sedation part of the protocol. And I'm not going to go into the specifics of that because I don't think anyone's super interested in it. But this is just kind of what appears in the app. It has sort of like how you do pain sedation with the drips, how you titrate it. And there's an order set that goes along with it in our EMR. And then it just like describes CPOT and RAS for people if they're not familiar with it. So I think our med students, our residents, our fellows, our APPs all seem pretty facile with it. And I've noticed since we started using it that people seem to pay more attention to the protocols. As far as the role of ketamine and sort of subdissociative analgesia, we only recently added it as an infusion option in our ICU. It's not really a standardized part of our pain and sedation protocol. So I'm curious to hear what other people are doing at their programs. There is a paper, a pragmatic RCT that came out of Houston that showed that they had decreased opioid exposure in the severely injured patients when added to an oral multimodal regimen but they needed like a monitored setting for this. So I'm curious what other people are doing because right now it's not really within our protocol, but we do have it as an option. As far as regional pain blocks go, this is all managed by our anesthesiologists, and they have put together sort of their own protocol of what they recommend for their multimodal pain management. And then they have come up with a rib fracture scoring system, which is based on the Ottawa group's experience, which I'll show you what that protocol looks like. But it involves like the number of ribs fractured, whether it's unilateral, bilateral. They consider age, they consider performance on IS, and then if multimodal has been attempted or not. And so some of the blocks they'll use are these serratus plane blocks for the anterolateral rib fractures, the erector spinae plane blocks, posterior and lateral rib fractures, and then they have some other options as well for sternal fractures or post-sternotomy patients. And then just a few pictures of what they do under ultrasound guidance for both of these types of blocks. And some of the benefits, which maybe aren't particularly described in the trauma population, but are kind of accepted for using peripheral nerve blocks, are just how it assists in pain control, reduces opioid use, reduces ileus, improves pulmonary function, reduces pneumonia and atelectasis, reduces delirium in the hospital. And then like quicker participation in physical therapy, reduces transition from acute pain to chronic pain, and then has faster ICU discharges to step down. We don't really use a lot of neuroaxial, like epidural type pain management. I think part of that is just because it requires a monitored bed or like really kind of an ICU bed in our hospital, and we just don't have that. We aren't kind of at a place where we could admit people just for that in the ICU. So we tend to use more like peripheral nerve blocks and multimodal if we're able to manage pain that way. And then in terms of how our anesthesiologists came up with their protocol, they went off of this Ottawa rib fracture protocol, which is I think led by Dr. Tierney, and then ours is kind of an adjusted version of this one, which is basically what ours is based off of. And then our anesthesiologists looked at their own data, and then they kind of modified a few things and decided that 5 was the number for the perfect cutoff for us. So that's what we use as sort of our consideration to have APS look at our patients for peripheral nerve block that they might benefit from. And then they're going to look at this kind of prospectively and maybe look at it in a way that results in more than a QI project in the future. And then some of the other peripheral nerve blocks that they use, Arvin just kind of included this for us to look at, because we don't really say, oh, we're consulting you for X type of block. We're just like, oh, hey, can you see if this patient is a candidate for blocks? And then they kind of pick whatever they think is the appropriate block. but they definitely help us out with like some of our amputation patients, definitely the rib fractures that we talked about, a lot of our orthopedic patients that need help with like pain control and extremity. We also, they help us with like our big abdominal wall reconstructions for other pain control options. And then finally, I was just going to put in like probably some of the best data looking at multimodal pain regimens came from Houston. They're really great at putting together these prospective RCTs. This is like a paper from, I guess they were looking at their 2010 to 2017 data and their initial protocol for multimodal pain control. It included tramadol, but in this original paper, they found that by using this multimodal pain control regimen, that they were decreasing opioid use in that time period compared to like kind of pre-implementation, which in this study, it was equivalent to 11 milligrams less of oxycodone and 17 milligrams less of hydrocodone per patient per day. And then they had another study that came out, I don't remember what year this was, but they compared a regimen that didn't involve tramadol. So it was like no opioids at all. That was just Tylenol, some sort of like NSAID, pregabalin. It's kind of the same things that most of the things that we use. So I guess it was Tylenol, naproxen, gabapentin, lidocaine patches, and then PRN opioids. And they found no difference between that and then their prior regimen that did include the tramadol. So, I mean, definitely great data. We don't have currently we don't have a multimodal pain control order set in our EMR. I discovered when I was putting together this talk, and like all the residents are just putting together their own pain control options. And I looked in our app, and I was able to find some information about multimodal analgesia, but it didn't like really pop up in a place that you would expect to find it. So I didn't actually know that it was even in our app. So definitely some opportunities for improvement there. But it kind of says like when we should consult APS, and then it kind of gives some suggestions about what sort of multimodal regimen one could use. So I think the opportunities for improvement, putting together this PowerPoint for our own program, were just that I discovered we had a sort of a rib fracture regional pain consult protocol that was actually within our app, but I didn't know it existed. So perhaps some of my colleagues don't know it's there either. And then we didn't have a standardized multimodal pain order set for trauma in the EMR, which, could be done and would be kind of better for patient care, so that each intern isn't kind of coming up with their own multimodal pain pathway. And then role is misspelled. Sorry, guys. The role of ketamine was not well defined in our protocols. So I think those are a few things that we will work on in our own program.
Thank you for that. That's great, Dr. Byerly. And then we'll keep all questions towards the end. And then the next one to bat is Dr. Lundy.
Thank you. I hope I'm off mute. I am. Beautiful. Well, in the next few minutes, I hope that I can convey to you my perspective on the implications of chronic pain in the treatment of the acutely injured patient. I'm going to review a little bit about the initial treatment, the importance of treating chronic pain before the acute pain, as well as some useful adjuncts for this patient population. And most importantly, I want to emphasize the consequences of undertreating this population and implications for their future care. As with any patient, a thorough history is important. It's best to understand how to guide their acute treatment. You have to know the etiology of their chronic pain. Do they have any trauma or injury? Do they have fibromyalgia? Who manages these? You must do a very thorough med rec, including review of their PDMP. You really need to understand what medications they take for chronic pain, and if there's any concern they may not in fact be taking them appropriately. Not infrequently, folks with chronic pain have a concomitant substance abuse history. Their pain may be the very thing that exacerbated this. You'll want to ask to be sure about other symptoms: anxiety, depression, insomnia, nausea, the abdominal symptoms, constipation, things of that nature. And if available in your hospital, do not wait. Engage the pain teams. Early involvement can be very helpful to avoid a spiral of poor pain control. And I usually alert the patient and say something like, I have a group of colleagues whose sole focus is to ensure your pain is controlled during your stay. I like this because it sets up the expectations and it helps the patients know you're on their side and won't ignore their pain. So that can be really helpful. And past admissions or bad experiences can inform how they're going to experience pain during this admission. So you don't want this to influence their expectations because it can actually make the pain way worse. If I can impart anything on you during this talk, and like very quickly, you cannot treat acute pain without treating chronic pain. You absolutely need to resume their home pain regimen. And if something about this makes you uncomfortable, phone a friend. But if you do not reorder their home medications, you will be trying to pour acute pain control medications into a giant big empty bucket. You must understand that people on chronic narcotics frequently have what is called opioid-induced hyperalgesia. People on these long-standing opioids from chronic pain may have developed this hyperalgesia because the paradoxical response to the opioids themselves, and this can actually make them more sensitive to certain painful stimuli, which is then exacerbated in the acute setting, leading to quite a problem for you. If you don't fully know their regimen, or they can't tell you because they're altered or sedated, you have to monitor for withdrawal. The clinical opioid withdrawal scale can be really helpful with this if it's already done in your system. It's always something that you can use. I think Epic largely has this pretty easily spelled out, but I'm not entirely sure about other systems. They might also be taking more than prescribed. So this would be a really good way to monitor if they're going to withdraw in that case. This is not the patient to order 5 to 10 milligrams of oxycodone in as their acute pain management. It's not going to do anything. You're going to be frustrated. The nurses are going to be frustrated and the patient's going to be frustrated. And then you will create a cycle of mistrust. In that vein, you do need to set expectations. It is important to be clear with patients that you will do everything you can to treat their pain. You should share with them your plan. What medications will be involved, whether or not a pain team will see them. You'll also want to say that although you cannot make their pain go away completely, you can certainly make it manageable. And that's really the goal. I always share with folks that we have a lot of different medications to help them to attack the pain, quote, end quote, from every side. Just a reminder, do not forget this group is particularly susceptible to constipation, so please make sure their bowel regimen is scheduled so you do not end up with major complications like, say, stroke or colitis that really sets them back quite a way. So I always start, you got to schedule the Tylenol. There's no downside to this, and the inflammation is the main driver of acute traumatic pain, so might as well take care of that problem. I think NSAIDs are fantastic, but frequently not used in the TBI or long bone orthopedic injuries. There's really not great data there, but it can be difficult to keep your consultants happy if you order these without talking to them, so that matters. In terms of neuromodulators, gabapentin is an excellent adjunct. Lyrica can have some insurance issues I found at the time of discharge, so I don't usually start Lyrica, but it's certainly one that you could consider. But you definitely need to understand the side effect profile and reduce dosing if there's renal impairment. It will be very useful if a patient has alcohol use disorder as well, which I won't get into in this talk, but a story for another time. Methocarbamol or Robaxin and Flexeril can be useful, but you gotta be really careful in the older, frail patients as they can become very sedated and confused, and that can be quite complicating. And I actually think frequently underused in the trauma patient are PCAs. It's kind of an excellent way to get a better overall idea of what your patient's needs are. Watch them on a PCA for 24 hours and then calculate their needs, and then you can convert this into an oral regimen if you're having a really hard time. In addition, I find it gives this patient population a sense of control. And I find that particularly helpful, especially in patients who fear pain from previous admissions where their pain maybe wasn't optimally controlled. And these are frequently folks who are in and out of hospitals. So you got to be really mindful of that. I think if there's any opportunity for neuraxial blocks, regional blocks by anesthesia, this is certainly the patient population to use them in. because their tank's already full of the narcotics. You're not going to hit them in the same way that you would, you're an average patient who's narcotic naive. I would say get them done as early as possible. Try not to wait. And with that, I want to spend a couple minutes talking about ketamine and methadone. I just as a sort of piggyback off of Dr. Byerly's talk, we actually don't have a protocol for this. And in the institution I'm in now, this has to be ordered by like an APMS or acute pain service. But in past experience, this is sort of how I've managed ketamine drips on my own. So when I think about using ketamine, especially in the chronic pain patient, I'm not so much looking for reduction in use of opioids. They're already on them, like they have to be there. But in people with opioid-induced hyperalgesia or really high tolerance, this is an excellent adjunct. I know that there was a recent randomized control trial that shows it does not reduce oral morphine equivalents, but that's not actually what I'm trying to do in the chronic pain group, so that doesn't really apply. I'm trying to give them an alternate pain treatment since they're already so sensitized to opiates. And I'm not trying to supplant the opiates they already have, but ketamine for this group has been shown to be significantly beneficial in folks that require a large amount of opiate medications or have some degree of opioid tolerance. And when I think about using ketamine, there's sort of 3 doses that you want to keep in the back of your mind. One being sort of the standard pain dose, which is about 0.3 mg per kg. You start to get a little bit more sedation with about 0.5, and then 1 is more of your anesthetic dose, and that really kind of counts a little bit more as like a monitored sedation. So you do have to be careful there. But if I'm starting an infusion, this is a little bit different than how most of the studies do this. And I think it's part of why they're not seeing such significant results. But I always do the pain dose bolus at 0.3 mg per kg. And then I start the drip not at 0.1, but at the pain dose of 0.3. And I think that's where the big gap is in a lot of the studies. And then if uptitration is required, you got to rebolus. Otherwise, you're not going to hit that level at a reasonable amount of time. And then I go up by 0.1 on the drip. So rebolus with 0.3 and then go up by 0.1. The max dose is 1 mg per kg per hour. And I'll tell you, most people aren't hitting that and staying alert, or they're starting to get some of that dissociative side effect and things of that nature. I am pretty excited about methadone. I have found it really useful as a second-line agent in the right patient. If you're thinking to yourself, how am I going to give this patient the oxycodone or Dilaudid in this exceedingly high dose that I have ordered? Or, oh, wow, I have given this patient a ton of narcotics and still there is no improvement. Methadone could really help you here. It inhibits serotonin and norepinephrine reuptake in the CNS, and it antagonizes the NMDA receptor. So basically, it mitigates pain and modulates the interpretation of the pain stimuli and reduces some of those other side effects of pain, and helps reduce some of that hyperalgesia and the opioid tolerance. So it can be really, really helpful. But you got to know a couple things about methadone because it's not just a free miracle drug, right? Before you start it, you got to get an EKG. And you have to double check with pharmacy that they aren't on any medications that might interact negatively with methadone. And I always start low. And as you notice, I wrote here TID. So I start low in a TID or QID fashion. You think of methadone patients going once a day to the clinic to get their methadone. That's not how it works for acute pain patients. And during that time, I kind of keep the other opioids in there as PRNs. So as you start the methadone, you should actually start seeing them take some of those PRNs less. And as needed, you can increase the methadone. In acute pain, you can titrate a little bit faster, but not super fast. Maybe like in a day or 2 days, you might be able to go up a little bit. But I wouldn't swing it too high, and you will need to keep monitoring their EKGs to make sure they don't have any cardiac changes. I think the biggest issue is what to do at discharge. This varies by institution and by where they're going. I've seen places where methadone can get delivered to a sniff, but that's not super common from what I found. And if you're having a tough time, you can engage your substance use team if you have one to help condense into a more standard daily or twice daily dosing. Or you can get a little fancy and consider a cross taper to buprenorphine, or just wean it back off once the acutely painful stimuli is improved. You all might be worried about causing delirium with polypharmacy in these high doses of narcotics or some of the adjuncts that I've discussed, and surely that is a valid concern. However, you need to recognize that poor pain control is a huge contributor to in-hospital delirium. In addition, poor pain control can lead to agitation, which is frequently treated with psychotropic medications. And these folks are definitely the ones to watch out for in terms of over-sedation. I do think the most upsetting thing is when a patient with chronic pain who may have had poor pain control on other admissions or who inherently feels judged by their providers once again has a bad experience and leaves AMA because their pain wasn't managed. We can do better for this group, right? I mean, I know it can be frustrating to deal with this, but you need to check your own bias and make sure you have the skills to deal with this patient. And if you need help, you should definitely ask for some. If we undertreat pain, it creates a sense of mistrust in the healthcare system and the team, and this can set you back with patients and even prolong length of stay. And it can also inform future admissions, so be very wary of undertreated pain. Unfortunately, chronic pain and substance use is a pretty troublesome continuum. If chronic pain is mishandled, folks may turn to more sinister ways of acquiring their pain medications and can often fall into patterns of abuse. If you're concerned this has occurred or could occur, involve the addiction team if you have one, or make sure that patient has follow-up with a chronic pain clinician who can monitor this. I think one of the most interesting resources I've found I actually learned about at University of Arizona, and this was bridgetotreatment.org. They have really good resources, and if you're comfortable, they have some clinical pathways for titrating methadone and buprenorphine in the acute setting. And that's been a really great resource for me as I've gone on. So one of the sort of last points I wanted to make is staff education is paramount. You have to talk to the bedside providers and nurses about how to manage pain, give the ordered pain medication as it's ordered, and prepare for the frustrating chronic pain patient in acute pain. We know these are very difficult folks to work with sometimes. They're scared, you're scared, there's a lot of narcotics, there's a lot of different medications that can be very overwhelming. But the team needs to recognize that past trauma and the current trauma is going to inform how you care for these patients now and in the future. So hopefully I was able to give you some tips and tricks. I know I don't have a ton of protocols for this, and I think it's because these patients are really hard to protocol because they're all really different and what they're experiencing is really different. So just wanted to thank you so much for this opportunity, and thank you to Dr. Anand for inviting me to participate.
Thank you, Dr. Lundy. That was a great talk. Our next talk is with Dr. Ratnesekera. She's going to be talking about pain control in our injured older adult population.
Good evening, everyone. Hope everyone can see my slides. So my objectives for this talk is to identify physiologic changes in the older adult trauma and acute care patient, to utilize available guidelines to help focus your pain management in the older adult, and then figure out what the optimal pain regimen may be for the older adult. I have no disclosures. So we all know that there's a pretty significant population growth in the older adult population. And the population back in 2022 for age greater than 65 was about 17% and is predicted to grow for more than 25% by 2060. We all have, all of us working at trauma centers and even in non-trauma centers know that falls are the leading cause of injuries in our older adult patients. And injury related to falls are the leading cause of death in the older adult patients. When you look at the age-adjusted fall death rates, it has significantly increased by about 41%, and from a decade ago to now. This is just a population growth curve. You can see that back in 2014 to now, that there's a significant incline or a growth increase in the population age greater than 65. So why does this matter? Because we're seeing a lot of patients who are elderly with injuries. Their most common injuries may be traumatic brain injuries. They could come in with cervical spine injuries because they have a pretty significant degenerative disease and cervical spine stenoses. They could come in with rib fractures, and they could come in with pelvic and hip fractures. So as we get older, there are several physical and physiologic changes that occur. And some of these can influence the type of injuries they have. Osteoporosis, as we get older, makes our bones weaker and more prone to fractures. Frailty, which is an assessment of physiologic and physical reserve. And the literature and guidelines have taught us that we all should be using some sort of a frailty assessment when we're treating for our elderly patients. And whether they are trauma or emergency general surgery or other subspecialty. Sarcopenia is when you have muscle wasting, when muscle is replaced with fibrofatty tissue, another sign of frailty, mobility issues, and protein calorie malnutrition. Arthritis, dementia, Parkinson's disease, all of these disease states kind of change their gait and change their sensory input. Ambulatory dysfunctions due to other comorbidities or chronic spine issues or pain issues, vision and hearing problems can alter how they see and hear traffic lights or see a step that's coming up and miss it. And other comorbidities such as diabetes and heart disease and hypertension can also affect your injury, your gait. So we know we always should be using pain scales when we're assessing pain in adults and children. But in the older adults, especially those adults with dementia, delirium, coexisting medical illnesses and polypharmacy, frailty, it might be difficult to assess their pain with the normal pain scale that we use. So other than the normal pain scale, we should be using scales such as the PAINOD pain scale, which is a pain assessment in advanced dementia, or the functional pain scale, or the Dolo +2 scale that we used for patients who cannot verbalize. Excuse my dog who's barking in the background. So we talked about physical alterations. Now we should talk about physiologic alterations that can occur in older adults. There's a decline in their homeostatic mechanisms and organ functions. There's a decrease in total body water, an increased adipose tissue. Their hepatic function declines, so which can reduce hepatic clearance by up to 40%. If they're really protein calorie malnourished, then you could have a decrease in serum albumin and protein binding capacities of drugs. You could have a reduction in your renal clearance. If you're giving sedative medications, patients may have a diminished response to hypercapnia. There's variations in baseline prostaglandin levels, which can increase your risks of renal and gut injury with NSAIDs. And they have decreased sensitivity to cholinergic receptors, making anticholinergics more harmful. So what medications should then we use in our older adults? Well, we all know the American Geriatric Society published the Beers criteria. Every 4 years, they come up with an update. I'm sure you all have read through the list. It's a long list, and it includes almost every medication class. So the Beers list, for those of you who don't know, are broken down to 5 categories. The potentially inappropriate medications, medications to be avoided in specific conditions, medications to be used with caution, and potentially inappropriate drug-drug interactions and medications requiring dosage adjustments. So now you must be wondering, well, boy, what should I prescribe my older adult who's injured or the acute care surgical patient? You also see that most of these older adults who are coming to the hospital have already been on every single one of those Beers list medications already prescribed. So what am I doing more harm than good if I prescribe pain medications? What do our societal guidelines tell us? So there's 2 guidelines that are important, I think. The World Society of Emergency Surgery and the ACS TQIP best practices guidelines. Both of these guidelines kind of shape what we should do, especially with older adult frail patients. And here's a summary. Using a multimodal pain regimen, which has been emphasized by my previous colleagues who spoke today. So acetaminophen as a first-line agent, we're using that around the clock. Just a caution that the drug clearance does reduce with age, as I mentioned earlier, low body weight, heavy alcohol use, and malnourishment. So if you reduce your total daily intake to 2 grams for patients who are greater than 80 years old, you should be okay. NSAIDs was encouraged by Dr. Lundy. I agree with that, with caution that it does carry a GI bleed risk, and you should use it at the lowest dose at the shortest interval. If you have elderly patients who have renal insufficiency, history of GI bleeds or ulcers, platelet dysfunction, and hepatic impairment, you might want to avoid these. Regional and peripheral nerve blocks are very important for older adults, patients. If you have patients with hip fractures, those peripheral nerve blocks can really help them. Isolated extremity fractures, rib fractures, I think it's important to have thoracic epidural anesthesia, but like in my institution where we lost our pain service, this is a luxury. So instead, perhaps ultrasound-guided intercostal nerve blocks or other type of nerve blocks can help these patients. If you have older adults with exploratory laparotomies or thoracic procedures, if you can have access to epidurals, great, but if not, other types of blocks such as tap blocks may help these patients significantly. What else? Well, multimodal pain regimens can also have gabapentinoids. Our SICU pharmacist always yells at us when we use gabapentin in our elderly patients, but because it does increase risk of sedation, but I think it could be used with caution. Lidocaine patches, immobilization of fractured limbs and ice packs, and then using the lowest dose opioids for the shortest period of time, and then de-escalating the opioids to off when they have recovered or when their pain regimen, multimodal pain regimen, has taken effect. So this table is actually from the American College of Surgeons Trauma Quality Improvement Guidelines. They're recommending with their recommendations. NSAIDs, they're recommending chronic use, not to avoiding chronic use. Ketorolac, indomethacin to avoid. Skeletal muscle relaxants to avoid. Tramadol, SSRIs, TCAs to use with caution. So what do we do? Well, we actually have a specific elderly patient admission order set that lists the Tylenol, lidocaine patches, gabapentins, early mobilization, and pulmonary toileting. I think in the future, if we could use clinical decision tools to alert our providers when there's a medication interaction, or if there's a harm for certain medication, would be an opportunity. But using your EMR and order sets to guide you is going to streamline the process in admitting these patients. So in conclusion, identifying patient-related factors that could alter their physiology is important. Assessing their pain adequately is important, and use of multimodal pain regimen should help your patient mobilize freely. Thank you.
Thank you. That was a great talk, Dr. Ratnesekera. So we have our three panelists here, and it's about my time, 2:38 p.m. So we have a little over 20 minutes to take any questions. There was one question that was asked in the chat, which was which app, for Dr. Byerly, which app do you use for your protocol or guideline updates?
Oh, let me take a look. Ours is just called the ROH Trauma. I'd have to ask our trauma program manager who they had developed the app. But if you're interested, you can email me and I'll find that out for you. It's sbyerly1@uthsc.edu. I'll put it in the chat.
Great. Any other questions from the audience? We would really like this to be as much for you as it is, for us putting it on as well. Any questions regarding pain control? Looking at the column here. I do have a question regarding what's your strategy for muscle relaxants? Because it's put on, in some cases I've seen it put on across the board. There's one type of muscle relaxant. Others, it's very selective. In what case do you use what type of muscle relaxant?
So I was, we are educated by our Saskya pharmacists that Robaxin is probably less dirty than Flexeril. So our go-to is Robaxin as a first line.
Okay.
I tend to use them less after watching some folks get actually a lot crazier with the Robaxin than other things. But I think I don't love it for an older adult. But for the sort of younger, robust population, especially for folks that actually are not enjoying their opiates, I feel like it can be okay. I don't love mixing it in as much with when you have a bunch of other things. They're like on a drip and a PCA and like all that. That's not maybe the right person, but like the young healthy person who like broke their femur and they're admitted us because it was a high mechanism and they want some muscle relaxant. Like I don't get so nervous with that. Whereas the older adult patient, I find they just don't do great unless it's a excuse me, a significantly reduced dose, like the baby doses of Robaxin, Flexeril, things of that nature.
And I have two questions here from the audience. What do you find to be the biggest barrier to adequate pain control? That's one question.
So I can speak for the elderly population, I think it's underreporting and not being able to really identify what pain manifests as. Is it the moaning and the groaning that's their underlying pain? Is it the grimacing when with turns? I think the elderly patient is more complex, especially those who have altered neurologic exams. I think that's the biggest barrier in the elderly population.
And speak for the chronic pain crew since I sort of already talked about this a little bit, but I think it's frustration by the team with the patient or vice versa. Like,
Yeah.
I think it's can get really hard because sometimes the chronic pain folks get like lumped in with substance abuse, or they are so terrified that someone's not going to control their chronic pain that it makes their pain worse because we know that if you have that expectation that you're going to have pain, you will have it. And so it's creating that trust with them being like, we've got you. We're going to take care of your chronic pain, take care of your acute pain. And if we're not doing it well, we'll consult people that their whole job is to take care of pain. And I think if you have like a chronic pain team or an acute pain team or really any of the pain teams or a substance abuse team, they can be really helpful. But you got to be careful when you tell the chronic pain patient we're consulting the substance abuse team. That doesn't go over well either. And so it's
Right.
just people that are sort of predisposed to experience symptoms because they do it on the outside, they sort of become that patient. It's like kids who are sick for a long time, they're like then the sick adult. It's the same thing, and trying to make sure that you're meeting them where they're at.
Yeah, I often find that when I'm at bedside with the patient, they're like, well, I asked for pain meds. And I'm like, did you ask for all of them? They said, yes. And they said, well, the nurse told me that's all I have for now. But the communication between the nurse and the team doesn't happen to bridge the gap that, hey, the patient's requiring a lot of pain control. Their pain is still not controlled. Can we give something else to escalate it further? And so I find that sometimes a barrier with bedside nursing and the patient. And I try to reiterate that to improve communication with both parties. The next question here is, what is the role of cryoablation for rib fractures?
It's funny because I was going to ask the audience a similar question about the cryoneurolysis. I know our APS team is excited about, I think, trying to do more of that in the future. I'm not sure what brand we got, but somehow we now have that kind of cryoneurolysis machine. So when we're rib plating people, we can use the little the little probe and like freeze. And so I don't really know. I guess we're just kind of in our nascency of using it, but I know that there's a lot of interest in it.
So I use it routinely with all the rib fixations I do, and my group. And mostly we learned it from our cardiothoracic colleagues who do it routinely for their sternotomies and thoracic procedures. There's a ton of data for the elective cardiac and thoracic patients, not so much in the trauma patients. And in some of their VATs, they use it under VATs visualization, whereas we do it externally. So sometimes I wonder, I know I'm in the intercostal space, but am I really targeting the nerve? It would be better if you're doing a concurrent VATS where you can actually see the intercostal bundle and direct it towards the intercostal bundle. But you know, with fixation and with cryo, I feel that we're seeing an improvement in how patients mobilize in pulmonary toilet post-op. So I think there may be a benefit, just not studied.
Okay. Is there a specific protocol at your institution?
No, we have the machine. You put the probe onto the intercostal space for till it gets to negative 40 Celsius degrees, and then it, it defrosts and you remove it. And you're supposed to do it 2 centimeters from the spinous process. So
Okay. We began using it a little bit here. Our thoracic surgeons use it quite frequently. And again, we use it externally, at least that's where we've started using it. And so far the evidence has yet to be determined whether it helps on our end, but you know, if you're doing it that much, that's something to consider, you know, publishing or discussing further. The next question is, would Precedex would a Precedex drip be used for multimodal pain control purpose in the ICU, and what's your experience?
I've really only used it for kind of sedation.
Me too.
I'll let someone else speak to the pain parts of it.
never
Thank
used for pain.
Yeah. no.
I tend to use it for as an anxiolytic for patients. It does have some degree of pain control, and it does, I think, help with in terms of sleep as well compared to other sedation mechanisms, but no, not really for pain. Not really for pain. And then the next question we have is, what is one thing that used to be the norm, the standard, that now you would never like to see happen for your patient?
Huh.
Versed. But that's not really
No,
pain,
but
that's
that's
more
okay.
sedation.
Um, I I feel like one of the things that I feel like is always like the norm, and it's not that I don't want it to happen for my patients, but like everyone always is ordering that Oxy 5 to 10. You can in fact give Oxy 2.5, which I particularly love for the older trauma patient. You don't have to go straight to 5. And then that way, like when the older, sweet little lady is like, but I don't want to take the narcotics because I'll become dependent on them. You can be like, look, I'm going to give you a baby dose. You're not going to get addicted. It can be really helpful. And just kind of, again, meet the patient where they're at in that little baby dose. And even don't freak out. But you can schedule narcotics, especially for the geriatric patients who don't know how to tell you that after living through the wars and the depressions and all the things that they live through, that their pain is real. You can schedule that really low dose. Obviously, you have to monitor them and like make sure they're not becoming over sedated. Like maybe you don't have to wake them up from sleep to give them that narcotic, but sometimes that at least then the nurse is always going to offer it, saying, well, they never asked for their pain meds. Well, at least they're going in. That can be helpful. I realized I expanded more on that.
I have some more questions here. Let's see. Does anyone in your group, in your surgical group, do the regional blocks for the patients with rib fractures in terms of, you know, being preemptive, especially if you don't have a pain service available?
Yeah, so because we lost our pain service, we actually had to get the ER doctors to teach us how to do the rib blocks under ultrasound guidance. And we had like a simulation lab for the surgeons and, so yeah, our partners do that.
Okay.
My partners used to enjoy, at the end of his X laps, putting some concoction of Exparil, and I forget what the dose was, and it was basically doing like his little tap block. But we did our own, I guess APS did their own kind of QI project and compared those patients to, whatever controls, and basically found that the pain control was better in the ones that they were doing. So that's kind of been abandoned, but but I would definitely do it if there wasn't another option.
Do you do tap blocks frequently in your XLAT patients, like across the board, or 'cause we've started doing them a lot more frequently here?
We do them a lot more. Um, I wouldn't say it's routine, but I think we do a lot more of it. Partly just because APS is willing to do
Do
them
it.
and they're helpful. I've definitely worked in places where we didn't have access to kind of regional pain services, and so we just didn't use them.
Mm.
Going back to the question about something we were horrified about in our training that we used to do routinely, there's nothing that I was like horrified about, but I do think it's cool that multimodal pain control has become so widely accepted because, we didn't do it as an intern, it was like, I was
Yes.
giving like IM morphine on the floor because that was like what the thoracic surgeons wanted. And I found out you had to give them a lot more morphine if you're giving an IM versus like IV.
Then IV.
But I think it's great just with like ERAS and everything. And then especially with like the opioid epidemic, I think it's great that there's just been this huge shift in the culture towards like multimodal first. I think that's been a great change.
Very nice. Well, we're down. Any more questions from the audience? We have a few minutes left over.
I had a question. What are your thoughts on lidocaine patches, especially in the SICU?
I think there's very little risk, but I don't know how much benefit there is.
I love them. It's just like it's kind of like a full liquid diet versus a clear liquid diet where like it feels like moves are being made and maybe they are, maybe they aren't, but like you're
Yeah.
like, oh yeah, you're having some pain from your, okay, yeah, sure. Let's just put a Lido patch next to their incision or next to their chest tube site. And the patient's like, yeah, like we're making moves. So same thing with the
Yeah.
full liquid diet. I'm like, oh, okay, yeah, we're going to advance to fulls today.
One of my
Like the same thing.
one of my partners is right now doing a study on lidocaine infusions,
Oh, yes.
which I think has a lot of potential. He's basically looking at lidocaine infusions versus ESP catheters or peripheral blocks with like continuous infusion versus I think maybe even just placebo, like nothing.
Mhm.
Because I don't think we fully understand, based on what he's sort of talked about, we don't fully understand how lidocaine works in these like ESP catheters and stuff. Like, is it actually hitting the nerve? Is it getting absorbed in the bloodstream from just like bathing the muscle?
Mm.
Like, we really don't actually know. So that's what he's trying to figure out. So I'm super excited to see kind of what he figures out
Yeah,
from that
that will be very
standpoint.
interesting.
Because like, what a great other thing. I mean, yes, there's obviously lidocaine toxicity and you can watch out for that, but that could be,
Especially for the chronic pain
yeah.
individuals.
And we have, I mean, our pain team will put people on lidocaine drips here, which was something I hadn't seen before. So clearly something I need to learn more about.
Mhm.
But maybe
And
we'll
then
have
one
to
last question, IV Tylenol. Does anyone have any opinions, history of utilization with it?
I think it's amazing.
Yeah, we switch them to PO once they can tolerate it. I think it's still more expensive, right? The ofuramin.
Mm.
Yeah.
So we switch them to PO as soon as that's feasible.
There used to be a fear that it was so expensive, much more expensive than oral Tylenol, and that, there was like an ordering barrier. You're not allowed to order it unless you say that this person is absolutely NPO and cannot tolerate oral medications. But now I think that's liberalized, and I think it's a great drug, first line.
You use it in your older adults?
Yeah.
Okay. Any other questions from the audience? Well, I want to thank everyone for attending today's grand rounds. I'd like to remind you to please submit your sign-in sheets to the AAST office by this Friday, July 18th. Thank you and have a wonderful evening. And thank you to our panelists for joining us. And thank you for Caitlin Sanders for helping us out through this entire process. Thank you.